Well, good afternoon, everyone, and thank you for the invitation to be here. Yes, I'm just going to spend a few minutes talking about how we've begun to try and use the advent of the integrated cancer systems that are now starting up in London to the benefit of end-of-life care. So it's somewhere... Thanks, Rob. Well, we all have to have souvenirs of meetings, don't we? I found more exciting ones myself, though, in the past. Okay, on we go. This is London, as you can see. And London now has two integrated cancer systems. The London Cancer Alliance, within which I've been working, and that's why the slides have London Cancer Alliance at the top, and why that's favoured with the white colouring across the bottom of this map. Now you can see that it roughly forms a crescent, and so that's what the LCA is now lovingly known as. But there is also a complementary integrated cancer system for the northeast and north of London, which is just called London Cancer, confusingly, and also lovingly known as the Blob, again, for fairly obvious reasons. And that's the grey bit with no landmarks in, because that's really north of the river, and we down south don't go there. Now, this is the mission of the London Cancer Alliance, and you're not meant to read it all. There are some bits highlighted, though, and you can immediately see, if you go through the highlighted bits, reduce the number of avoidable deaths, combining clinical and academic strength to localise expertise for common cancer, to improve outcomes, improve access, and drive up standards. Well, the drive up standards is fine, but you can see from the rest of it that this has nothing whatever to do with end-of-life care. If anything, this is trying to make sure that the end of life never comes if the integrated cancer system has anything to do with it. Now, the way that they're working on this is that they're promoting prevention and early cancer detection and supporting GPs in doing that, and with a very strong public health presence as well. And then trying to improve patient experience and linking with the results of the National Cancer Patient Survey to do that, getting equitable access right across the care pathway, making services local if they can, but where things are rarer and you need to centralise expertise, to make sure that is done, rather than, to put it crudely, a number of amateurs scattered across the piece doing their best but without great effect. And then using the resources that we have across London to underpin best research to drive progress forward. Now, the thing about all this is that in spite of the LCA and London Cancer's best efforts, it's quite clear that not everybody is going to be cured of cancer overnight. And so the question was asked from palliative care, where is our sort of work within your scope? And the answer was that it was in a group called survivorship. End-of-life care was sort of where survivorship stopped, it seemed. And that we felt was not entirely appropriate. And so very promptly, London Cancer Alliance set up a palliative care group alongside some of the other pathway groups that it had, because this is how, sorry if that doesn't show up terribly well on the screen, this is how the whole structure goes. They have a set of pathway groups, each of which is dedicated either to a tumour group or to a particular subject area, in our case palliative care, in another case survivorship. And these are quite tight-knit groups that can survey the service that is available and make decisions about how those services could be better in their totality. A plan which is then fed up to the Integrated Cancer Systems Clinical Board, which sits under the Members and Partners Board, which is populated by the chief executives of the main cancer providers right across London. And so that is where major decisions about the reconfiguration of services, it is intended, shall be made. And so what pathway groups do is they're charged with looking at outcomes. Now, of course, on the whole, they're looking at how curable or how cured particular types of cancer are. For us, we're going to be looking at what access there is to palliative care, issues of equity in end-of-life care across London. There are some what are called model of care recommendations. I'll show you ours in a moment. And all the pathway groups are tasked with living up to these model of care recommendations within their particular clinical area, and then to define and encourage best practice. And so in order to do all this, these pathway groups are really quite small. They're only about a dozen strong, so that there can be decent discussion and actually some decisions made, rather than there being really very large and diffuse talking shops. Now, this is the model of care plan, which was produced right at the beginning for commissioning support for London about 18 months, nearly 2 years ago. And within that, the model of care recommendations for palliative care are these. And you can see instantly the angle from which these come. With implementation of the NICE guidance on supportive and palliative care across London, well, that's fine. Complex palliative interventions happening at specialist centres, well, what might those be? Well, you can see the examples given up there, and they are really very highly technical interventions, most of them most often done within interventional radiology departments, and so they're not actually anything to do with everyday end-of-life care, or indeed even specialist palliative care providers. And then all staff should be trained in generalist palliative care. So this is clearly coming from the generalist angle, and again, one wouldn't have any complaint about that. But this is a document that has come from way outside end-of-life care, and certainly from outside specialist palliative care, which leaves us in palliative care with a few challenges. Because many of the objectives of the LCA, or indeed the London Cancer, are not directly applicable to palliative care, but there are some unifying links. And in particular, those are that we're all concerned with improving the patient experience, we're all concerned with education, in our case in generalist end-of-life care, and of course we're all interested in collaborative research to improve the quality of care that's on offer. Specialist palliative care involves many providers, and actually most of the beds and most of the providers are not within the NHS, quite uniquely, and so the third sector needs engagement here. And outside hospital, a key issue for end-of-life care is localism. When people are dying, they A, want to be at home, and if they do have to go somewhere, B, they do not want to be miles away where their family finds it very hard to spend time with them. Palliative care is much more than cancer. So although we have utilised LCA in order to provide a platform for palliative care assessment which goes across the old networks, we're aware that this is a discussion which isn't just linked with cancer or confined to cancer. And then some things need a pan-London approach, not just the LCA, which brings me to London Cancer. Now, London Cancer doesn't actually have a palliative care pathway group, but what it does have is a pathway group, in effect, which has been set up as stimulated by the onset of the integrated cancer systems and is associated very strongly with London Cancer, but is not actually an embedded part of it, as the group that I'm involved with. I chair, by the way, the LCA, Palliative Care Pathway Group. And so we both have a palliative care pathway group of one sort or another, and we're aware that we must not work in a silo here. So in terms of the LCA one, we've defined the core membership. There are a dozen of us, drawn from specialist palliative care across our segment of London. And we have started having monthly meetings. We've had about 3 of them so far. So what we're going to do first is find out what's already done. The integrated cancer system requires all its pathway groups to assess the services that are there, and we're going to conduct a baseline audit of palliative care service to get levels of service, identifying variations and inequities. Yes, we're going to look at NICE guidance, but we're basically going to be looking at NICE end-of-life quality standards as much as the implementation of the earlier guidance. We're going to be assessing what user feedback mechanisms are being used by service providers in our specialty, and also what education outreach they're offering and to whom. We're required to map those complex palliative care interventions. We'll do that, but I think that's a relatively minor part of our work. But then we will be moving on to reviewing the issues of interface between specialists and generalists in end-of-life care across London. Now then, we've got to do these things, or some of them, in as joined up way as possible. So finally, I just want to show you what we're doing in terms of linking across London. We have had one joint meeting with representatives of the London Cancer Palliative Care Group, which is rather drolly called Palliate, P-A-L-L-E-8, because one of the largest hospices in London is in East 8, so PAL E8. And we have agreed together, or are in the process of agreeing together, the audit template, so that we will have a joined-up service audit done in the same way across the whole of London, which will give us an idea across London entirely where the gaps might be. And we're also going to be seeking agreement and action on pan-London issues in end-of-life care. So, for instance, the standard referral process for palliative care that is operable wherever you might be across the capital. And as Rob has just been describing to you, also an agreed approach to resuscitation decisions as well. And the joint input from these two integrated cancer system associated groups are also going to form an advisory group for the London Clinical Senate in end-of-life care, in which context we hope to link really very closely with the end-of-life care commissioning group, advisory group for the Senate as well. So this is very much a work in progress. It's in its infancy, it's just beginning. But the integrated cancer systems are giving us the opportunity of a joined-up improvement in service quality for people nearing the end of life in London that I think we've never seen before. It's an exciting prospect. Thank you very much.